going to be 3 plenary talks that really start the meeting focusing in on COVID-19. And those 3 talks are really summing up what we know today. How has the experience in Spain, has it taught us about headache? What has it taught us about practice? What did it look like being a headache specialist in Spain who maybe had to be redeployed to do something different? I think that we're going to learn a little bit about their experience, which is a little different than the experience in the US, and hopefully really put our thinking gears on, because this isn't really over. And if there's a potential second wave, we have this opportunity to do it better. And so I think just seeing what the experience has been and really allow us to start thinking about how we can do it better. There's another talk from the experience in New York City, and that will focus a bit about what it looks like in New York, what it looked like during the peak, what redeployment looked like, but also what that did to residents and fellows. And I think that's really important for any of us who are headache educators. It's already so difficult to have that time with the students and the residents and the fellows, and to have that time shifted, very difficult to think about. And I know in our program, we have a fellowship for headache. This isn't extremely common, but it exists. And we've had to really think about what is that fellowship going to look like over the next 6 to 8 months if patients are very anxious about meeting with multiple providers, because that puts them at risk. We also have medical students. I usually precept a first-year medical student who is sent home middle of the year, so his year was cut short. I also have resident clinic, and that was cut short. So I think that hearing from others how they are going to handle this, and there's several abstracts talking about residency education and headache in particular. So I think it is going to allow for that languaging about what do we do now for the next year when things are going to look very different? How do we make sure we're continuing to put that education forward? Otherwise, the long-term outcome of that is that we're going to have less residents interested in headache. We're going to get less fellows. We're going to have less providers. And so 1 year is a really big deal to us. The last talk is focusing on practice management, is focusing in on an article that was published in the last month about COVID-19 and migraine. Really talking about how migraine is an essential problem, and that it's very difficult for patients to have to stay at home and skip over treatments. It's just really not an option. I think many of us were very anxious when the government started to shut down elective procedures, and we weren't sure what to do with these patients who are receiving onabotulinum toxin A for chronic migraine. To me, that's not an elective procedure. This, for some of our patients, is really their life. And so just walking through some of that experience, walking through some suggestions when patients are stuck. Again, I don't think this is the last we're going to see. Things are going to probably get better. But if there's a surge again, we're going to need to have some things in our back pocket that we can talk about what to do for these patients. But that's really the focus for COVID-19, those 3 talks. After that, it's really focusing on all this great science that is coming to play in the last year. And I think that's extremely important. When we realized that the scientific meeting was not going to be able to happen in person, I think the biggest thing, being a member of the scientific committee, that we were anxious about for the programming is, one, we've put a lot of time into this program. We've reviewed hundreds of amazing abstracts, really top quality science that's talking not only about what's coming in the field, like, for example, the best abstract is presented as a Wolff Award. This year, the Wolff Award went to Dr. Antonio Russo, who's going to now be able to present his work looking at migraine and cutaneous allodynia. Allodynia is a symptom that patients have when their scalp and their skin is really tender. Usually it happens during a migraine, and it's a sign that the migraine is out of control. This is how I explain it to my patients. Your brain's on fire, and now I can't put that fire out easily with a pill or a medicine, and it's a sign that this might get worse. It's also a risk factor for progression from attacks of migraine to having chronic migraine, where you're having continuous symptoms most of the time. So they took a look at these people with cutaneous allodynia, and they were trying to see, is there a change that occurs in their brain that puts them more at risk for allodynia, which puts them more at risk for chronification. This is fascinating. If we have a way, a biomarker of some sort, even if it's an imaging marker, to say to patient, I've put you through the scanner, it looks like you might be more at risk for chronic migraine, even though you're only having 3 to 4 migraine attacks per month right now. If we don't treat this more aggressively, your 5 to 6 years from now is not looking so great. So let's get on top of this versus someone who maybe doesn't have that marker and they're a little more hesitant to start on preventive medication because perhaps they're a young woman who's thinking about getting pregnant. So this kind of tool 5-10 years in the future, extremely helpful and very relevant to clinical practice. So our fear when this meeting was going to have to be halted was you take signs like that and you don't bring it to the forefront. I mean, they can't wait a year. We need to know this kind of information. So I'm excited that we're going to get to see that, and we're going to get to see a lot of the top abstracts presented as well.